Hello. I'm here and delighted to introduce the next session, which I think has been almost perfectly teed up by the final question in the prior session about the importance of data considerations and essentially reliable data lead to reliable results and algorithms. What we're going to do is have 4 talks followed by a moderated panel, which will also include a 5th invited speaker. And each talk will be about 15 to 20 minutes, and then we will reserve all questions for the panel. So thank you very much. My name's Amy Abernethy. I currently have a rather long disclosure slide, which I think is most important, that I live mostly in the health tech space, work with a number of companies focused on data, and I'm the Chief Medical and Chief Scientific Officer at Flatiron Health in New York City, which is now a member of the Roche Group. So I'm really going to talk about data considerations and specific features of data as we think about preparing for a computational world within the context of precision oncology. And I think my core point in the beginning, middle, and end is going to be this: reliable data, produce reliable algorithms and reliable results, and thinking about the details of the data and making sure that we understand what's underneath the hood matters. If we think about the longitudinal journey of a patient, a person with lung cancer perhaps is diagnosed, may have initial information at the time of diagnosis, including pathology, maybe some biomarker testing at that point in time, or the person may go to surgery or radiation and have that information generated later. The person may have a series of treatment steps, some of which happen early, some of which are only followed by the recurrence of the disease, and also may have a number of interfaces with the health system. The key point is that as this person travels along the journey of their cancer care and diagnosis, data is being collected in different places and different types along the way that referentially makes sense within the context of the individual's disease, but also in aggregate forms the data sets needed for the computational methods that we're talking about. And these data sets are coming from many different places. As we think about the data that we need, we're now not usually talking about one single data set, but the aggregation and the amalgamation of data sets. They may be already organized and ready to go, or sometimes they're dumped into a single space, such as a data lake, and only organized in the context of what's needed. But it's really important to understand what's both available as well as how it's organized and how you're going to pull from those data sets as we think about being ready for computational methods. The Duke Margolis Center for Health Policy has been focused in this last year on thinking around real-world data. So I think about these as passively occurring data sets available as a byproduct of care. And what are the features around real-world data that we need to think about? One of those features they've described as data relevancy, so making sure that the key data elements that you're going to need for the computation are indeed available within the context of the data set. And the second key feature is data quality, making sure that you understand how complete the data are for any particular critical variable, whether or not you can rely on that variable, and whether or not that variable appropriately represents the task or topic at hand. The other key feature of data quality is that of provenance and being able to have confidence about where the data was sourced and how you can understand how the data was transformed by the time it gets to you. All of which then goes into this context of thinking about fit for purpose data, or the data that you need. And as we think about algorithms and algorithm generation, you need fit for purpose data to generate your algorithms. And then when we think about the application of the output for algorithms within the clinic, we need to be able to reliably pull the right data within the context of this individual patient at this point in time. When I think about data sets and all of those different data sources that might be combined together, different data types have different technical, contextual, and governance features which are going to influence the reliability. And this just gives you some examples of the different kinds of data sets and their different features. So for example, all the way over on the left, I think about instrumentation data. So we've talked about multidimensional and scalar data earlier this morning. And so for example, omics data and data sets like this are often generated by machines. They're highly reliable when you think about the ones and zeros coming off the machine. The problem is these are massive data sets where problems include storage, being able to appropriately transfer them, being able to appropriately analyze them in a consistent and confident way, and the fact that the analyses may change over time as the algorithms change over time. Meanwhile, we have other data sets, such as electronic health record data or administrative data, where the features of the data sets are actually, these are small data sets. The problems are more likely to have to do with need for data curation, problems with data completeness, and fundamentally issues around governance and who owns what. So understanding the features of the data set and what's going to get in the way or actually also be an enabling factor is very important as we think about these data sets. There's also data sets that only are otherwise ephemeral unless they're collected at the moment in time that the event happens, such as patient-reported data. Paying data from 6 months ago and asking the patient now, how did you feel 6 months ago, is not really relevant, and the only time to collect the data is within the moment. So patient-generated health data in particular is very critical that it's collected at the time that it's most relevant to the event. I'm going to talk for a moment about imaging data, just in his example, and some of the issues that you might run into as you think about imaging data. Raw images themselves are best. They are best in terms of the ability to now get back to the actual image and what it represented, but there are massive storage challenges, and they're hard to identify, especially if you want to reuse them over time. Pixelated data, so the pixelated data from the raw image, is not the same thing as interpretation of the findings, and the information that's needed for subsequent analyses and algorithms is in the interpretation, often not necessarily the pixelated image to begin with. And so you have to understand what data you're working with and what are its availability and challenges. Often, one of the things that people will do is, if they don't have access to the image itself, is to deal with, for example, reports in an electronic health record. And the reports themselves now are textual information based on dictation or transcription or somebody typing into an electronic system. And then these have to be curated into some type of analytical file that now can be processed from an algorithm standpoint. The problem is that the curation of the unstructured information in those reports requires actually understanding as well. So for example, over here on the left, what you see is a CT scan and the information in the radiology report that can be curated with NLP or abstraction or other techniques into now data sets that are available for analysis, but that curation itself may not be accurate. And what you see over here on the right is that somebody has written on top of that report additional information in order to improve the accuracy of a particular report and interpretation, and I'll come back to this. The other thing that's important as we think about imaging data is that the findings in routine clinical practice, what happens in a oncology site across the country, whether that's in the community oncology, a hospital setting, or academic setting, is often different than what we might see on third-party independent review. Although these different types of interpretations need to be understood within context. And interestingly, what you see here is that the physician said that this particular patient's tumor had actually responded, while when you look at the original report, the report had said that the patient's tumor had grown, and the reason was because there was different referential reports for the oncologist that the oncologist was looking at as opposed to the radiologist. And the key point here is that in order to then use this information in any algorithm, you have to understand exactly what's going on in the context of this individual patient across time. So my core point here is the interpretation of scans as a kind of data set requires information about context over time. So when we go back to the idea of about a patient that lives across time, there's a series of clinical events that are a combination of different kinds of data sets, clinical data, pathologic data, radiologic data, and biomarker data all coming together in context, so that when the patient is diagnosed, there might be pathology data and radiology with specific report. As this person now, for example, progresses, there may only be radiology with missing pathology, and you have to understand the level of reliability of the data set that you've got at the time of data progression. And then later across time, you may only have other types of data sets, such as only biomarker data and written reports, but no available pixelated image. And how you understand these data sets across time becomes particularly important. The other thing is that data completeness matters. So all of these might be points when you'd have a radiologic image available to you, but there might be times when those images are missing and you have to fill in those data gaps. The key point across all of this is understanding how all these come together so that you have underlying data sets that are reliable and can inform your algorithms across time. Finally, there are proxies that you might use. So for example, one proxy that we often use is RESIST as a way of interpreting radiologic scans and understanding whether or not the disease has progressed or responded. But this is in itself a set of proxy analyses, and into which we turn what originally started off as pixelated data into interpretive data and now into categorical data. And you need to understand what these different kind of data sets mean across time. And what's interesting about RESIST is it also is referenced to the actual time and event of the patient's treatment. So for example, response is a feature of treatment. The key message across all of this is you have to understand data in context in order to reliably use it in your algorithms. The other thing about imaging data that I think reminds us well is that images themselves are hard to de-identify. So if you want to store them and reuse them over and over across time, you have to remember that these images often contain key data points that are patient protected information that you have to decide how you're going to deal with that in an appropriate way. Another key point is that the representative data sets also leads to our ability then to generate reliable algorithms, and that there's a risk of bias if we don't have adequately representative data sets. I think you saw this come up a little bit in the last session when there was some discussion around wanting to make sure that we adequately reflect people from all backgrounds. And this is just an example from the Flatiron data set. And what you see is that we're not very representative of just the middle of the country. And so we have to constantly think about what that means in terms of the risk of bias in our data sets. And the other thing is many data sets in the United States do not adequately represent outside of the United States. And how does the issues of the representativeness of the data set itself then become reflective of the algorithms that we generate and the risk of bias within those algorithms? I'm not going to spend a lot more time talking about this, but I think it's a key aspect as we think about algorithm generation across time. In this particular example, this is a paper that we recently had in JAMA, and what you see here, what we were looking at is the likelihood of next-generation sequencing to lead to improved survival in lung cancer. And it was important when we did this work to appropriately balance for race, ethnicity, age, and other patient features. And one of the things that we saw was that the likelihood of patients to have, for example, next-generation sequencing in the real world was different by race, ethnicity, and age. So the patients who were younger and who were from more well-off racial and ethnic backgrounds were more likely to have next-generation sequencing. And this is particularly important as we think about getting balance in our algorithms going forward. Another key thing that we have to think about with data are data gaps. So we talked a little bit about completeness, and I showed you a challenge we've seen with scans and having availability of all scans. But there's lots of different problems with completeness. And one of the things that we can think about is how do you amalgamate or pull data sets together to deal with data gaps? A lot of times what we're thinking about is, for example, how do you blend together electronic health record and genomics data so that you have clinicogenomics data? Or how do you add patient-reported outcomes to bring in patient symptoms in order to fill that gap? And there's a lot of ways these days that we can start to think about using solutions to fill data gaps through data linkage. And this is an example of a tokenized solution, but we can think about everything from ledger-based solutions to tokens to other ways to now combine data sets in order to have reliable information that's combined across data types. If you're going to do that, though, one of the things to do is to make sure that when you link data sets together, you constantly recheck the reliability and the fidelity of the underlying data sets that are now coming together. And there's a series of papers that are starting to come out that allow us to cross-check the underlying data sets to make sure that if you link, for example, clinical data from the electronic health record with genomics data, you don't lose fidelity for either one of these data sets. In this particular example, it was cross-checking the ability to link different types of mortality data to ultimately get to an aggregate survival data set. and importantly, having a way of constantly checking the data sources and ensuring that they're as complete as possible. One other way to deal with data gaps is to create data proxies. So we've historically, for example, used a data proxy in comorbidities, something called the Charlson Comorbidity Index, as a way of documenting the likelihood of a patient having one or multiple comorbidities. And this data proxy may be hard to generate in all types of data sets. It was really easy with claims data, but it may be harder with new data sets becoming available. And so generating new proxies for comorbidities going forward may be needed. And so what we're seeing more and more now is data proxies that allow us to represent key features in data sets when you need them. Another issue in personalized medicine specifically is the availability of certain types of data that you need in order to drive personalized medicine algorithms. We have talked in prior sessions about biologic and biomarker data, specifically omics data, and making sure that you have the appropriate biologic features needed, for example, immunoprofiling or omics data within your data set at the right point in time. What we're starting to see as well is that as the data sets themselves and the algorithms are starting to generate more and more understanding of individuals with specific biologic features, we're starting to see problems and opportunities as it relates to data sets that are predominantly small cohorts. So in this big data space, what we're starting to find is that more and more of big data is actually moving towards small data, so that you have, in fact, data sets that represent small numbers of patients represented, and thinking about what are the data features within small data sets that we need to understand, especially as we imagine that these patients are often now identifiable, and how do we work with them in a de-identified way. A lot of this then ultimately comes down to issues of data reliability and quality, because if the underlying data set is not reliable, then what you end up with is unreliable results. And importantly, thinking about the reliability and quality of every single type of data point that leads to the aggregate data set that you're using for your algorithms is a key task. Each data point can actually be measured in a consistent way. You can describe completeness for each data point and how likely it is to be complete. You can describe how likely it is to actually represent the topic, a variable, or outcome at hand. And that's now becoming critical in an aggregate way of individual patients across time, because individual patients now reflect cohorts of patients, which ultimately drives the underlying data sets for your algorithms, as well as the output of your algorithms in the clinic. One of the things that we're starting to see more and more people work on are standardized mechanisms to document data reliability and quality. So for example, standardized reporting of data completeness that now get appended directly to data sets, so that you have this information at your hands as you start to work with these data sets. And back to the Duke Margolis work that's happened in terms of getting to research-ready data sets, one of the issues that's now starting to come up is that we need to document reliability and completeness, essentially overall data quality, not only in the source data sets, but also in the derived data sets that are used for final analyses and data set generation. So there's need to do documentation of reliability and quality twice, both at source data systems as well as at transformed and final analytic systems. The last 2 points that I'd like to make are the following. The first is that as we think about the use of these data sets now to derive and drive decisions in the clinic, the data sets that are going to drive those decisions actually have to be available to us in real time, or at least recent enough that they can inform this particular patient's care now. If the only data set that you have in order to inform care represents the care of this individual 2 years ago, and now their disease and their situation has changed, that data set is now not going to be accurate and recent enough to care for this individual patient. So being able to understand data recency and essentially how much follow-up is available for individual patients, cohorts of patients, and overall data sets is another key feature that we need to make sure is well documented as we move from creating algorithms to using algorithms for personalized medicine in the clinic. And finally, we'll talk this session about privacy and security, but it's critical that we're constantly thinking about where these data sets are held, how they're secure, how they're moved from place to place in a secure and consistent fashion, or if we're going to work with the data sets in place in federated models, that we're doing so in ways that allow us to have consistency in output of algorithms. And so issues of data security and privacy are becoming, if anything, even more and more critical. So with that, these are some of the critical features that I think ultimately inform us as we think about going forward and having reliable data that will produce reliable results, and a couple of policy considerations to take us into the next part of the session. First of all, the details about the data matter. We need biased and unreliable data to lead to biased and unreliable algorithms, and we need accessible data at point of care. We still also need to deal with the fact that there's many different types of data sets requiring many different types of experts in order to help understand them and also contribute them to our algorithm and precision medicine development. Therefore, on a policy side, we need to stimulate tech innovation that solves all of these problems. We cannot skimp. We can't go for the cheap because ultimately we're expecting these data sets to do a lot of work for us. We need to expect transparency about data reliability and quality, as well as the accuracy of the output of the algorithms. We need to create standards for documenting the reliability, quality, and accuracy of the data sets, and we need to be able to have those standards available for everybody, and we need the workforce who knows how to work together and work with these data sets as well as generate the algorithms. So with that, I will say thank you very much, and we'll move to our next speaker, Mia Levy, who will put this now into context.